All right. Well, as promised, it is 2:02. Thank you, everyone, joining us across the country for this webinar of the Collaborative Family Healthcare Association. My name is Naftali Serrano. I'm a psychologist, and I'm the Executive Director of the Collaborative Family Healthcare Association. We are proudly an interdisciplinary association. We represent members or have representatives, members of the entire care team, from physicians to NPs to PAs to psychiatrists to psychologists and social workers and LMFTs and LCSWs and master's health professionals of different stripes. And we also have folks who just really care about integrated care across the board, foundations and payers, researchers. If you care about integrated care and are passionate about making healthcare work better for individuals and their families, CFHA is your home. So we're happy you're here. If you're here, it's because you care and are passionate about those things. And you're here because you're interested in a really great topic today. I love webinars that are skills-based. It gives me a new tool to work with and something that broadens my perspective. And that's what you're going to get here today from Daniel and from Larry. So you're going to enjoy what happens today. As usual, you guys know the drill with webinars. There's a couple of instructions in the beginning. The first instruction is you all are by default muted, so you can't participate with your voice, but you can and are encouraged to participate throughout the webinar. The presenters have indicated their preference that you just ask questions as we go, and I will be helping them keep an eye on either the question box or the chat box, whichever one sort of is more convenient and shows up. I'll just keep an eye on both of those, and the presenters and I will help make sure those questions are answered as we go. So please feel free to participate throughout. The only other technical question is that I often get is, are these recorded? And the answer is yes. We'll be recording these. These will go up to our Vimeo channel, which you can find on our website, integratedcarenews.com. So just a few days after today, you'll be able to go review the presentation, send it to friends, etc. We certainly encourage you to share and distribute this information far and wide. And last but not least, we certainly want to invite each of you, if you're not already making plans to be with us in Rochester, New York on October 18th. Our annual conference is there this year. I will tell you, and we haven't, I'm going to be sending out an email later today. We are actually we're on a record pace as far as participation. And why that's important for you is simply get registered and get a hotel room. We're going to put up a new link actually to an additional hotel because we are running out of room at our main hotel. So if you do have trouble getting a room, just be patient. That link will be up later today. And a hotel that's actually a kitty corner to our main conference hotel is already available. So we'll have that information. But if you haven't, check out the information at integratedcareconference.com. That's integratedcareconference.com. All the information you need to hang with some of the really nicest, most open people you will find who are passionate about topics like we're talking about today and the full breadth of what we call integrated care. Those people are going to be there in Rochester, New York. So we happily invite you. With all of that, I'm going to turn it over to our presenters so that they can introduce themselves. For these sorts of presenters, they are so well known, you don't even have to introduce them. These are folks who have great names in the world of integrated care. And so I am happy to have Daniel and Larry today leading us on this topic. Gentlemen?
Well, thank you. I appreciate the opportunity to be here. This is Dan. And Larry, can you hear or are you muted?
I can hear.
Okay, good. So yeah, welcome to this CFHA webinar. This is an exciting opportunity for me, and I'm sure I'm speaking for Larry too, to talk about a topic that I feel very passionate about, which is, of course, teaching healthcare providers to practice family-centered care. And so let's jump right in. And as was mentioned, we do welcome any kind of questions throughout. I'd rather take questions when they are relevant to what we're discussing instead of holding them to the end. And so let's see if I can advance my slide. We'll give just a brief introduction to some of the why of family-centered care and what that is exactly. Larry, why don't we have you start, maybe just describe the story that you were telling me a little bit earlier today.
Yes, so I'm Larry Mauch, and I'm also delighted to be here and have worked as a family-oriented behavioral health provider for about 35 years. In my entire career has been in primary care. So I'll tell you a story briefly that I think makes several good points. I was contacted by the inpatient team the inpatient team was in quite a bit of distress. They had a patient who had recently delivered the first child, and the patient was upset and wanted to leave the hospital. And the patient had a complicated delivery, which included a major tear resulting in a 4th degree episiotomy, and the patient had developed a fever. And the patient got increasingly anxious as her pregnancy unfolded, and then as she realized that she had this tear and was infected. And I got to the hospital room, and there was the patient and a couple of the docs involved in the care, and the patient was sitting on the side of her bed with her coat on and her bag tucked under her arm, and she wanted to go get her baby and leave. And I asked a couple of kind of, in retrospect, perfunctory questions that I'm sure the doctors had already asked, and I got nowhere. So I looked at her and I said, so this is a powerful experience. What's been the experience of birth in your family? Has anything happened that is important to you as it relates to birth and being in the hospital? And she looked at me, and her red face actually seemed to get twice its size, and she sort of burst into tears, and she said, well, when I was born, my mother had a large tear and she almost died. And I said, my goodness. And at that moment, what became apparent to her was that she obviously doesn't remember this, but her mother had obviously told her this story many times. And she realized in that moment that she was sort of fused with her mother's experience. And she sort of seemed to calm down. In retrospect, what I wish I would have asked, but I didn't, but the outcome was the same, was in retrospect, what I would have liked to have asked was, what would your mother advise you to do at this point? What ended up happening was she actually relaxed, and she said, well, I'm just so terrified. And I said, so I did say, so what do you understand the concerns of your doctors to be? Well, I have an infection, and they're concerned that I leave the hospital and things will get worse. And I said, right, I think that's true. They want you to be able to give the best care to your baby that you can. And so she actually relaxed, and she stayed, and she actually thought she was going to see a gynecologist. She was being cared for by our family medicine physicians, but the gynecologist's name that she had was actually one of our own family physicians. It all turned out well, but the point of this story is that it highlights a fundamental principle of primary care, particularly family medicine, which is that it's based in systems thinking. And that when our normal efforts to provide care aren't effective, what we need to do is look at the patient or the problem in a larger context. We need to expand our system. And that's sort of what that question did. And that's really what I've done for my 35-year career. I can't tell you how many times just seeing an individual patient with a common chronic illness like hypertension or diabetes, that I've looked at the patient and I've said, so what is it going to mean for your wife to change the way she cooks to accommodate this the new food schedule that you have with diabetes? Or the same kind of a question with hypertension. Or what does it mean for your family for you to change your routine so that you can start to build in exercise? How's that going to affect folks? Are there people in your family that want to support you? Do people in your family think about what kind of support you would need? All of these are questions that give us a view of the patient in the context of their family and more. What they do is they stimulate the patient to actually think about family change and therein improve the likelihood that our efforts to provide care for them are going to be more successful. So the comment that Dan put up is there's no family member present in the room. Research shows that about 33% of the time, about a third of the time, there's more than one member of the family. There's somebody else in the room besides the patient. So that means 2/3 of the time that's not the case. But the family, as I've always said, is always in the room in some way or another. And understanding their influence, either in a helpful way or in a way that might impede care, is critical to pursuing effective strategies. I'm going to stop with that, Dan, unless there's anything else you want me to say, and I'll turn it back over to you.
No, that's great. That's a great example of what I know you've seen for many, many times over 35 years of your career. I don't have 35 years of experience yet, but I have seen many examples myself. I've been the director of behavioral health now for 6 years at 2 different residencies, and I've had the privilege of working alongside doctors and social workers and you name it, integrated care settings. And I feel like one of the most important aspects of truly integrated care is integrating the family into the larger care team. We could talk all day about stories of how we've seen the benefit of families and family-centeredness adding to the patient's healthcare. I want to point out some of it maybe with less of a narrative base, but more of an analogy using puzzle pieces. Where in a traditional medical setting, you have the patient who has to go to various services, whether it be a psychologist or a physician or some specialist of behavioral health or medical services. And thankfully, with the help of CFHA and many other organizations and emphases, the healthcare field in general is becoming much more integrated, much more team-based and multidisciplinary, which allows the patient to fit neatly into this integrated healthcare system. But what we know through experience and research for decades now is that many of our patients are already connected to a system of people that have a lot of influence over the health decisions that they make. And these people aren't necessarily medical care providers, but systemically connected to family. And if we are not able to collaborate with a patient's family in some sense, I guess I should say when we are able to really be family-centered, it allows the patient to be fully surrounded by many people who have influence on the health decisions and the health behaviors that they have. So with that little perspective in mind, I believe family-centered care is not just a great idea, but in many cases essential, especially when the family is contributing to some of the problems that the patient is facing. And we can talk more examples as we go through. The ideas of family-centered care are not new. We're not here today to suggest that they are. In fact, I want to emphasize that there have been many different books and articles published for literally decades. Family therapy and family medicine, for example, was published when I was 4 years old. And there's a rich history of care providers across disciplines recognizing the importance of considering the patient's family in the context of their family. And today we want to emphasize not just why to do family-centered care, but emphasize more the how to do it. Because although we've known for decades that it's a helpful thing to do, there's a lot, I believe a lot yet that the healthcare system can grow into how to actually implement a truly family-centered care model and how to train healthcare providers to do family-centered care. And so if you're new to this topic, I encourage you to go and read some of these books. I've got the earliest versions listed here, reach back decades, but that one in the middle, for example, Family-Oriented Primary Care, a second edition came out in 2004, and then Medical Family Therapy has another edition out too. And in addition to these books, there's many articles, and even Family Systems and Health Journal has published quite a bit on this. And so I encourage you to read more if this is of interest to you and somewhat new. But let's move on into the actual how. We'll get into some of the tools that Larry and I have created and developed to help teach this. Like I say, I teach family medicine residents. I'm currently in the family medicine residency in Sioux Falls, South Dakota. I was formerly in Indianapolis. And a lot of colleagues and friends have been using some of these tools, and you're welcome to use them. We'll talk about an observation form and an electronic website, both of which are free to use, and they will remain so. We're not trying to make any money off of these. We're just trying to engage in what we feel passionate about. And so the first one that we'll spend time talking about today is what's called the Family-Centered Observation Form, or the FCOF for short. Many of you listening may know about Larry Mauch's patient-centered observation form. And although these are very different with a different purpose, they are very similar in a lot of ways. And this one kind of builds off of that one. And we'll talk more about that in just a minute. But in addition to the form itself, which we'll go over, we developed a website, which is an electronic training module that teaches anybody who takes it, whether a clinician or a trainer, about the skills that are listed in the Family-Centered Observation Form and how to use the form as a tool to provide feedback. And if you look at let me back up here and show you, right under the title, it says, "This form structures feedback and enhances self-awareness of family-oriented interviewing skills." And that's really the goal. It's much less about evaluation and more about a teaching tool and a training tool that either you're training yourself or training others. The electronic module is designed for both audiences. Now, I can see here in the chat box an audience question: could we have access to your PowerPoint slides? You could, however, you've seen all of them. From this point on, we're going to switch over to the website and demonstrate both the form and the website. And so I don't know that you'd really want the PowerPoint slides. You're welcome to find the website at the address listed there at the top, www.fcof.us.
Dan,
yeah.
Are the slides that you just presented included for the most part within the website?
You know, the puzzle pieces, the form, of course, is.
Yeah, but because I think that
the puzzle pieces are.
They are or they're not, the puzzle pieces?
They are, and I'll show you that in just a moment.
Because I think it's a very clever design, a way to teach that you've created using those puzzle pieces. And my guess is the person who's asking the question could use, and others would want to use, the puzzle piece slides as a very effective, concise way to get the message across to trainees, to colleagues.
Let me actually switch over to a web browser where I have pulled up the electronic module, and you can see it's got all what are there, 9 pages here. Can you see my cursor of my mouse, or is it just my screen?
I can see your cursor.
Okay, good. So you'll see, you scroll down and begin, and the very first page that it takes you to is a animated video, and the text of the video is listed here below, but I won't take the time to show the audience the video now, other than to, let me pause it here and then we'll skip ahead, and you can see the very demonstration I just talked about is listed in the video.
Actually,
so if you like that,
Dan, the video that you've created is even more compelling now that I'm thinking about it, than the slides that you showed on this presentation for the listeners.
You know, and the video does a good job of kind of setting the stage of the why is this important to learn? Why should I as a learner care about being family centered in my interviewing and improving my skills? And so, you know, I won't play the video for you now because of course you can go access it yourself. But at the end of it, and I would encourage you to, especially if you're new to these ideas, go watch the video. And then when you move to the next page, we jump right into what the family-centered observation form is. And so for the next, I don't know, 20 minutes, I'd like to go through some of this. We're not just going to read the module because I know you can do that on your own, but I'd like to highlight some key points. I'd like to really familiarize you with both the form and the website, which are, you know, these tools that you've come here today to learn about. So please feel free to ask questions as we go through. And if I happen to not notice a question, please maybe somebody point it out to me. The family-centered observation form has 6 categories. The first 2 are kind of introductory, and then you get to the meat of the visit, with the final one being more of a closing of a visit. Now, of course, medical visits vary widely in the purpose and length and, you know, visitors, who's present and how many. We've tried to make the family-centered observation form as adaptable as possible to the widest variety of medical visits. In fact, maybe I'll ask you a question, and you're welcome to type into the chat box. For those who are listening, what kind of observation forms do you currently use? What forms do you use now to provide feedback and to, you know, structure your feedback and help learners or yourself increase awareness of your interviewing skills? Specifically, if there are any that you currently use with a family-centered emphasis, I'd love to have you chat in if you use any of those. And feel free to do that even as I continue on. The family-centered observation form is 2-sided, and you only use one side per time. Here I'm showing you an example of side A, and you see the first 3 settings, categories of the 6. And you'll notice that in each one there are boxes that you can check as to whether the person, you know, demonstrated that skill or not. There's also, after each section, white space for comments. And I feel like it's as important to write comments as it is to check a box. Checking boxes is important because it can sometimes prompt the observer to look for certain skills and recognize the presence of them. But also, they can be very limiting at times, and it's important to have white space where you can, you know, add whatever it happens to be specific to that instance. And in addition to the check boxes, we encourage you to cross out anything that may not be relevant. So for example, if there is no other care provider in the room with the doctor, then of course you're not going to introduce it, and so you cross it out. And, we'll talk a little bit more about the differences in checkbox and scoring and stuff a little bit later.
Dan,
I want to emphasize that. Yeah.
Dan, may I jump in for just a second? So just a couple of quick comments. So one of the things that both of us have observed is that whether you're trained as a physician or as a behavioral health provider or some other discipline, there's a subset of folks that get anxious about talking to more than one person at a time. And what this form does is remind you that it's really important to establish a connection with everybody that's in the room. That's what the first row is about. And the second is that we've observed also from a lot of research that people get anxious about managing time, and they focus just on what they, the provider, want their agenda to be, irrespective of how many people are in the room. Agenda setting reminds us that it's really important to understand what the concerns are of the patient and of other family members. And just listening to what those are helps you use your time much more effectively and so both of those elements are very, very important.
Yeah. Yeah, I'd like to emphasize that that this form is directed towards family-centered skills, and of course there are patient-centered agenda setting. Somebody you're observing might do a great job at patient-centered agenda setting, but may forget to include that family-centered context. And so, you know, we've got a portion here: patient-centered versus family-centered. The healthcare provider may be patient-centered without being family-centered. However, we believe it's not possible to provide quality family-centered care without being patient-centered. You know, we emphasize in this module that family-centered skills are kind of built on top of being patient-centered, and hence the reason we have differentiated between critical skills or family-centered skills, and then the more fundamental, more basic ones, which have a square checkbox. The reason for the circles and squares has to do with simply adding up and determining proficiency level. And like I said, we'll get into that a little bit in a minute. I want to emphasize, though, that being proficient is not necessarily the goal. Sometimes certain medical visits, they just simply aren't as complex as others. You know, an acute medical checkup for a sore throat with one 34-year-old male who, you know, is in and out real fast is very different than a family. Yesterday, for example, I saw a family of 5 children, and both parents were in the room, and one of the children was being assessed for ADHD, and it was a very complex. Toys were being thrown around the room, kind of a visit, and it was much more difficult to manage that kind of an interview. And so a competent designation is not bad. In fact, a person might be very proficient at patient-centered skills, but still show up as a novice because the FCOF focuses on the ability to take a family-centered context. I think I have that here listed. He or she may be very patient-centered, but novice. And then there's some other articles and read. We want to differentiate this from any other interviewing skills observation form because it is specific to that systemic approach and understanding patients in their system, their family system in a systemic context. So let me go ahead and advance to the next slide, which is focused on this first section of the family-centered observation form. The person who is completing this electronic module is encouraged to click here, and then you'll have a link to the latest PDF version of the FCOF, and there, and you print it off and then follow along as we watch a series of videos. And the person doing so is encouraged to just look at this first box here in yellow while they watch this video of this doctor introducing himself to the patient and his wife, and I can't remember their name, but I'm sure if I push play on the video, you'd find it out. Be sure to use side A, and we'll talk about the difference between side A and side B in just a minute. So the person who's using this tool prints off the form and then follows along with this video in the same way that hopefully they will be able to in their own clinical setting, whether they are the clinician or an observer of the clinician. This first video you can see is only 21 seconds long. When you've completed your observation on the score, we encourage you to click here, which will allow you to compare your answers to our observations and kind of check yourself. For those who may not need more explanation, you could move on to the next page. But for those who maybe want to dig into a little bit deeper of each of the skills on the family-centered observation form, there's a brief paragraph about each one. So for example, why do I need to clarify the relationship between the patient and whichever family members they have brought in with them today? I personally made this mistake. No, actually, I'm not his mother. I'm his girlfriend, a patient once told me. I admit I was embarrassed. I made an assumption I shouldn't have, but it was nice to clarify the relationship. From now on, I ask things like, what is your relationship? Or who is this today here with you, Aaron? Or what's your relationship to Aaron? Or rather than just making an assumption. It's of course, we don't have the time now to go through each of these details, and neither should we, because you're welcome to access this module and read it for yourself at a different time, and you're encouraged to. But let me go ahead to the next screen, which is about agenda setting that Larry pointed out. There's just a brief overview of some of the research and some of the reasons why, and then again, there's another video where you're now following the same visit farther along, where this doctor is setting an agenda for the visit with the patient and his wife. And you're encouraged to use the second section of the FCOF. And again, when you watch that video, this one's a real quick one. It's only 1 minute and 31 seconds. Afterwards, you again compare your observations with ours. And if you need more explanation, then there is the detailed explanation of what is a good family-centered agenda to be set with the visit, where you're soliciting input from everybody and including your own goals and prioritizing. I will say here, of course, not every visit needs a full-blown comprehensive agenda set. In fact, many of the residents that I teach sometimes give me pushback, and they say, I feel like I'm wasting time by setting an agenda. But all it takes is one time of them getting lost in a visit that feels out of control. And they actually, most of the third years that I teach, they love setting an agenda.
And a good rule of
family centered.
And Dan, a good rule of just a good rule of thumb is anytime there's somebody else that comes to see to a visit, there's always a reason.
Yes.
In other words, people don't just come with the patient just because they got nothing better to do in their day.
Yeah.
There's always a reason, and not finding out what that reason is really misses a valuable opportunity. Sometimes the reason is caustic, because a batterer is trying to prevent a spouse from speaking, but most of the time it's for some important reason. An adult child wants to understand how to provide better care for a demented parent, or a spouse is concerned about a partner's declining health, or they both realize that they need to work as a team to manage a complex collection of chronic illnesses.
And regardless of the intensity of the reason why, there's always a potential benefit. For example, yesterday I saw a woman and she brought her sister with her. And I said, hey, how are you doing? And what brings you in? And is this your sister? And all the introductory stuff. And she said, oh, I'm here just because we're going shopping afterwards. And I figured it's easier to wait in here than in the waiting room. Pretty benign reason to be there. And yet her sister provided just a wealth of information that was relevant to this patient's care. And I was very grateful that the sister attended. So let me move on to the next page. Is not just the next section of the FCOF with another video. It is in fact a focus on content, emphasizing that family-centered care includes not just who or how you converse with people, but what you converse about. Because the content of a family-centered visit is, I believe, where a lot of the benefits are gained. So I have here 8 examples of content areas that are often asked about or could be asked about in medical visits. You're welcome to read those there. And I would encourage any of you listening, if you maybe see anything else that would be added, type it in the chat box. This is obviously not a comprehensive list, but if you see any other content areas that a clinician might ask about to get at the familial or system influence on a patient's health, certainly family history is asked about quite often. But so are let me give an example. I saw a patient a few weeks ago who has some chronic back pain, And we got talking about not just the symptoms and the intensity and the type of the numbness and the tingling or whatever it was, but also, how does this affect your husband? How does this affect your kids? How does your kids affect your pain? And what emotions or beliefs you have about the pain? And she was the only one in the room, but we got into quite a discussion about how her pain not only influences her, but also her family. She's not able to take the kids to school like she had originally done, and the husband was now working 2 jobs, and it was great to get into the content with her. We didn't have a lot of time, so of course I didn't ask all of the questions, and the expectation is not that you ask about all of this content, but if we neglect to discuss at least a few of the relevant influences that a patient's family member and family system has on their life, I feel like we miss some of what we kind of limit ourselves and limit our ability to really influence the patient in a way that's going to last. I won't spoil these videos, but for example, the man in the previous video was talking with the doctor about diabetes, and you get into some of the dynamics of the family that has to do with why he's struggling to regulate his A1C and blood sugar levels. But at the bottom of this page, I go into just 4 basic family systems concepts, things that were drilled into my head during my training as a family therapist. There's a lot of family systems concepts. There's degrees out there on this. I've simplified it just down to some four of some of the basics that I think are very relevant for doctors practicing medicine, such as triangulation. And I won't go into much more of that other than to point it out: circular causality, homeostasis, and then a family shared belief system. I will say, Larry, your example of the woman in the hospital who was kind of maybe even subconsciously adopting the belief of her mother's experience that she too would, have a life or death situation related to infection and the episiotomy. I think it's a great example of sometimes a person's beliefs are very much still adopted from their family of origin, and sometimes discussing it with the patient can free them up of some of the things that they don't necessarily want to own themselves, or they are encouraged to own it more fully, independently and individually, differentiating from their family.
Yeah, I think that's exactly what happened. And it's nowhere is it stronger than between moms and daughters around pregnancy.
Yeah. And end of life care. There's quite a few patients I've seen where everybody has a lot of emotions about what we should do with dad when he's no longer able to remember people's names and health is declining. So for the sake of time, let me move on to the next couple of pages. The next page is kind of the meat of it. We're going to be looking at all 3 sections of the FCOF. You're encouraged to read a little bit more about the actual skills that we emphasize and discuss here. And then we get to a video. Below is the family-centered interviewing process. Again, you can go and read more about these, but you'll see these 3 sections as described above, below, and previously are what the observer of this video is supposed to be documenting as they follow along. This video, you can see, is 4 minutes and 55 seconds. So it's substantially longer than the previous 2. And it's a great demonstration. I won't spoil the video, but this man brought in his, I think, 12-year-old daughter who has asthma, and he and his wife are kind of upset that she's not using her inhaler at school, and she's been hospitalized a couple times. And this family doctor does a great job of blocking his interruptions and helping the daughter's voice be heard, and helping them both share their perspectives and a lot of the skills that you see here, acknowledging the different perspectives and soliciting all perspectives, clarifying whether they need to interview the patient alone, and again, I don't want to go into too much detail, because then why would you need to go and read this later? But I think the video really demonstrates both the content, the process, and the skills, and allows a person to, I guess, get at the meat of the FCOF. And then, of course, as on previous pages, you can click here and compare your observations with ours, and see some of the comments that we've given to the doctor engaged in this patient visit. And let me move on to another point of these tools that I think would be important to point out, is the FCOF is a two-sided form, but you only use one side per visit. And the reason is they're the same form with a twist. Side A is to be used when your patient has a family member with them. It could be any family member of any age. It could even be a friend. Honestly, we define family very loosely here. Anybody that they bring in, as you mentioned, Larry, there's usually a reason why they bring that family member in, and the verbiage on the form is set up to be directed more to when family members are present. Whereas side B is to be used only when you have one patient in the room, but you still want to take a family-centered approach. And we'll talk about what that means here in just a second. Let me first point out that, or if you have one family member present, if the patient is unable to communicate. So for example, I was observing a resident do a well child check last week. The patient is 3 months old. And of course, you're not going to use side A where you're asking the mother and the child, but instead we used side B because the patient was really basically the mother, and the resident did a great job asking about the father's opinion, even though the father wasn't in the room of the child. In fact, the father had actually left the woman and was not intending to be a father to the child, and it was kind of a single mother, but she was very upset about him leaving her and wanting to raise the child according to his wishes because of some cultural beliefs that she had. But side B is emphasizes relational questioning. And Larry, you gave a demonstration of what you wish you would have asked to that woman in the hospital. Mm-hmm. Can you remind me what it was?
Yeah. So if your mother knew about your situation now, that you wanted to leave the hospital, what would your mother recommend that you do?
Yeah.
So it's a way of a relational question is a way of getting the patient to look at the world through somebody else's eyes.
Yeah, you didn't ask, what do you think your mother would want you to do? You said, if your mother was here, what would she say? Because then you're not asking for the patient's opinion, you're asking for the family member's opinion. And one of the most important, I think, or not most important, probably the most common relational questions that I see is, I think it's listed in here. Instead of asking a patient, the family member of a patient who's in maybe end of life stage, what do you think would be the best option for your mom? Sometimes it's better to say, if your mom could speak, what would she say would be the best option? It takes a lot of pressure off of the family member to be responsible. They don't have to say, I think this. They're able to say, well, if mom was here, she would say this. And it's very powerful as well as freeing question in that specific context. The goal of relational questioning is to provide you and your patient with a family-centered perspective. You want to bring the family into the room, even if you can't bring their bodies in. You want to bring in their opinions and their beliefs and their culture and because all of these things have such a significant influence on the patient. And to ignore them, especially out of convenience or ease on the part of the clinician, is to maybe even do the patient a disservice, because you may recommend a treatment plan that doesn't fit within their family context, and then they're kind of caught between you, the healthcare system, and their family. And so for the sake of time, I'll just get to the last page. There's actually one beyond this, but I just want to emphasize that the last section of the FCOF in the training module is specifically that. To use side B to to watch this doctor talking with this woman about, some of the postpartum struggles that she's been having, and wanting some counseling and maybe medications for the depressive symptoms she's been experiencing. And the doctor does a pretty good job, and you're able to mark here what she does and what she does do, and make some comments. And again, you could click here to compare your observations. And once again, there's a much more in-depth explanation of each of the skills if you have interest. And then the last page is some kind of maybe summary words. And then if you want to provide us some feedback on the training module, you're welcome to do so. And then some further readings if you're interested to know more about family-centered care. This is actually one of the books that I showed in my slide a few moments ago. So with that being said, I see that we have just over 10 minutes left. I want to make sure to stop and grant time for questions and discussion, if the audience has any. I don't know that I can see.
Yeah, I can't see if questions are being, there was one question earlier that somebody noted that I didn't see. But I have a couple of questions to stimulate responses, Dan, if you want.
Yeah, go ahead, unless we have others chime in.
So I'm, for all of the, I see that there are about 29 participants. I'm curious to know how often during interviews with individuals do you respond? Do you incorporate a question that asks about family member perspective? And you could answer never, sometimes, rarely, sometimes, or always, or most of the time. And just to be curious, and if everybody'd be willing to respond, we could just get a quick sense about how new. And I can't see your responses, and hopefully folks will be willing to share. Do you see responses, Naftali?
Sorry, I had to mute myself there. Yes, I do, and I'm tracking them. I'm actually typing out a few answers to things I can answer from the people. But yes, I can see the responses from people.
Oh, great. I can't see a thing. It doesn't, for some reason, they're not showing up. Do you see them,
Dan?
Dan?
I can't either. I don't see them.
Oh,
no.
okay. Okay.
I feel kind of isolated and lonely.
Sorry, guys. Yeah. No, you're not missing anything here. I'll read a couple of things here, actually.
That'd be great.
Dawn says, this is Dawn Prentice, says sometimes. Tara wants the question repeated, actually. So maybe you can repeat it. Fern says often.
Okay.
Could you just repeat the question for Tara?
The question is, during routine interviews, interactions with your patients when nobody else is in the room, how often do you ask one or more questions to elicit the family perspective or influence? Never, rarely, sometimes, or most of the time?
Yeah, so we've got a sometimes and an often. And guys, I'll just chime in just based on my clinical work. And I would love actually to have someone actually observe this, because what you think you do and what you often do can be different things.
Yeah, right. That's very true.
So I think that I would. Sorry, go ahead.
No, I was going to say, I'm to that.
Let that
point, I have been.
Yeah, we're doing the phone thing. I'll just say my comment real quick, and then Dan, you can chime in. But I think that I often do, simply because, to me, to understand the person's, as you've noted very well, values, their behavior in context, the contingencies that are important to our patients' lives, it's hard for me to disentangle that from their family context and their family system dynamics. And so I think I do, but what I love about what you have presented is that it would give someone a tool to evaluate whether I'm actually doing that. And I think that's really critical because, as we know from lots of other research in other sorts of evidence-based strategies, clinicians think they do things much more often than what they actually do numerically. And I'm wondering if that's the case for me.
That was to that very point. I was going to say, I experience that all the time. I have residents who I have them do this module, and then I have them record themselves and watch themselves using the form to evaluate their own medical care. And the majority of them say at the first that they include families quite a bit, and then kind of a post-test after they've trained and watched themselves, and almost without fail, probably I would guess, 60-70% of the time, the resident says something like, wow, I had no idea what I wasn't doing. I had no idea how much more I could have involved family. And, I think it's human nature. It's not a healthcare provider thing only. It's human nature that we kind of assume about us things that we don't necessarily know are true or not until we kind of take an objective spectator stance on our own interview conversational skills. And it is very insight generating to have a learner go through this process. I like to have them watch themselves first and then do this module. And of course they use the form to watch the videos in the module, but then I have them use the form to watch a recording of themselves, specifically with the intent to be as family-centered as possible. So not the same recording as they started with. And they come back with all sorts of good comments and insights on how helpful it can be to see yourself kind of from the spectators. In fact, one resident last week even mentioned, he said, it's almost like I'm watching tape after a football game. A team on Monday watches tape of the game on Sunday, not because they want to know who won, but because they want to watch the process of how the game unfolded. And he's like, I feel like that when I watch myself. And I think that's the power of tools like these.
Dan, can I ask the group another question?
Of course.
So I think that Naftali's point is a really important one, and that is that what we think we do and what we actually do different things. And the value of this form is developing an observer self. But some of one's ability to observe comes from training. So I'm curious, of the group that's participating, answer yes if you had family interview training as part of your formal training, and answer no if you did not. Just curious, what proportion of the people who are participating in this webinar have had some kind of formal family interview training?
Interview training or family systems training? Well,
families, either way, either one, just some kind of family training. I don't want to try to split hairs here. Some kind of family training to interview families, to work with families, to talk with multiple people, multiple members of a system at the same time, or to think about how they work together. So you answer yes if you've had it, no if you have not. Are you getting responses, Naftali?
Yes. I was just going to jump in. So it looks like the preponderance of folks, I've got 6 people so far, have said yes. Only one has said no.
Okay.
One, Dawn, has been through the family systems focused master's program. And I'll add my yes to that as well. I had live behind the mirror training.
Yes. So that makes a difference in terms of how you observe yourself vis-a-vis your comments, Naftali.
Yes, for sure. Absolutely.
Yeah, I think it's, my experience of training medical residents with these tools that we're presenting on today has the overwhelming thing that sticks with me after the couple of years that I've been doing it is it really is one piece in a growth process that to change and become skilled at family-centered interviewing and providing family-centered care is not an overnight change. It takes a lot of self-awareness, a lot of belief and trust in the process. And my favorite parts are when the residents have a patient and they discover the value of taking the time, which, time is precious. But when they take the time to ask about the patient's family and what it means for the family for the patient to have this illness, or how the family provides support or adds stress, when they have that moment of realizing that, the residents feel empowered, like they have a different skill set and, one more tool in their toolbox to really meet the patient where the patient is at, and offer some care that is more holistically focused, which I think a lot of at least the residents I teach, highly value.
So Tara noted an important comment that she had a family systems class as part of her master's training, but did not have hands-on training for the interview portion. Okay. And I think that's an important distinction as well, that just having a systems background doesn't necessarily prepare you for being in the room with multiple parties and learning how to attend to all of those factors and do the rapport building that you guys are pointing out. So this tool, I think, fills a crack in the training for folks who maybe have some family systems training or at least exposure, but not interview training.
Right. It's a worthy distinction. As the time is coming to an end, I thought of actually a couple of relational questions to leave the audience with, the participants with. And there's no need to respond, but one of them is, what would your patients think if you ask each of them about what their family perspective is on their reason for seeing you? In other words, getting the patients to look through the eyes of their family members, to give input about the healthcare concern that they're pursuing in seeing you. How would your patients feel about you asking that? I would just suggest that folks think about that. And the second question would be, I'm assuming that most people who are on this call are behavioral health providers. How would other members of the team benefit from you asking family-oriented questions, even when only an individual is present? Those are the two questions I can think of.
Yep, good question.
So those are great. That's a great way to end. Dan, do you have anything to say before we say goodbye to everybody?
I would just emphasize that this is not a finished product, and that any feedback is welcome and encouraged. We're continuing to do research on these tools and adapt and grow them. If this is a particular interest of any of the audience members, I encourage you to contact me and let me know, and let's collaborate together on really, not just talking about why it's important to have a family systems focus, but how to actually teach people to use the tools that can create the benefit. So my email address is listed on that first page of the module right here. And so if you would like to contact me, I would love to hear from you. And thank you for your attention and time.
And thank you, everyone. First of all, thank you to Dan and Larry for a great presentation, for the work on this tool. We'll be tweeting out the address to this tool on all of our social media platforms. So if you happen to forget it, we'll have it all over our channels here shortly. And of course, the recording is going to be available as well in a couple of days on integratedcarenews.com in the video section. So please check that out and let other folks know. Our job is to promote this kind of work, and it really happens very much through word of mouth. So thank you so much for joining us, and we'll check in with you soon, either at the conference or at a next webinar. Thanks.
Thank you, Naftali.
Thanks, guys.